Hello, welcome back to our panel number 5. I am very honored to welcome today two wonderful, experienced experts of spasticity. Our moderator of today will be José Pereira, who works in Luxembourg at Reha Center, and Paul Winston from Canada. Both of them are top-class rehabilitation doctors. So please, both of you, the stage is yours.
Thank you very
Thank you
much,
so much,
Monica.
Monica.
I think I have to say some words about Paul because
Yes.
I think I try to go to. It's a real pleasure for me to introduce him. He's an outstanding clinician, a researcher, book author, and educator, and his work is profoundly changing the landscape in neurorehabilitation, mainly in the spasticity field. So it's for me actually one of the most respected voices in our field. And on a personal note, I'm fortunate to call Paul a friend, but I admire him
I'm
especially
happy about
by
it
two
as well.
things, and we're just talking about it on off before, because Paul, two things he does is empowers patients and their loved ones and the caregivers, and also he encourages a lot our fellow medical professionals to innovate by teaching and sharing his skills and knowledge. So it's really great honor to have being here and moderating this. And I think Paul is going to share with us a wonderful lecture. Let's go. Paul, the
Yes.
stage is yours.
What I can say
Thank
about
you.
you two, actually, is that you both are very passionate, very emotional about your patients, because I've seen you both during work. So I can tell everyone that really the profound passion is there for both of you. Thank you so much. Paul, the stage is yours.
Now, do I see my slides? I don't see them presented yet.
Yes, you will. Mm-hmm.
Oh, great. Thank you so much for this great introduction. It's great to be here with you, Jose. Thank you to Monica for the invitation. So we are going to take all the work that you've done in pain management and anesthesia, and we're going to apply it to the pain from spasticity and the management of the spasticity. And this is really a live world innovation that's happened just over really the last 7 years. So I'm going to give you a bunch of cases, and we're going to talk about them today. I really need to thank Dr. Daniel Vincent, who is the anesthesiologist that actually proposed it when we started doing nerve blocks. He said, why don't we just do cryo? And we only had one ancient Oxford Lloyd machine back in 2018 when we started. So Dan did all of our initial cryo, but he actually became a patient when he fractured his ribs with an unfortunate bike accident. So he's lived the experience. Everything I'm going to talk to you about today is in our textbook. And you don't make a lot of money from selling textbooks, and it all goes back to education. But our second online edition has all the really advanced targets, and hopefully it's going to be print on demand very soon from Amazon. What I want you to understand is that when we think about cryoneurolysis, we are targeting nerves, and we are always looking for these nerves, the sural nerve, the suprascapular. But nerves are everywhere. It's like an upside down tree. Every inch of your muscle has some sort of nerve branching to get to it. And in our textbook, it actually shows you all of these targets on how to dissect spasticity and pain. And there's videos. So the QR codes will take you to these videos. So anything I explain today will be easy for you to see. So the premise of treating spasticity and pain is we know that the lateral pectoral nerve supplies the shoulder for pain, but it's the main driver of adductor tone of the pec major. We also have pec minor. So we spent the last years deciding what muscle, if you have a contracted shoulder, which are the muscles that are attaching there. Apologies. We want to make sure that we know how to target every single nerve in the body. So if we go back, I'm a rehabilitation physician, as is Jose. And what we know is that patients don't just have pain. And in the pain world, you often look at pain scores, but we are functional people. So if we look from a purely pain perspective, this is a neurologic patient with an acquired ill on oxygen in the ICU. But when she went to stand up, she couldn't walk because she had a very arthritic knee. She had no feedback or sensation from her feet. And we did geniculars. And what's so surprising is immediately she was get up and walk and she could be discharged home. So looking at it from a functional perspective, we are taking patients with neurologic disabilities and figuring out where is the pain coming from. And we publish this, and all of our publications, you should know, have videos to show exactly how we did it. Now, going into the spasticity, everything I said, as you can say, you can find the case report and then watch the video. But what if we treat more than the joint? So we're going to start talking from pain until muscle. So often in patients with shoulder pain, arthritic pain, they can't move their range fully. And is that due to just the arthritis or is there muscle involvement? So this gentleman, he's a chronically unhoused older man, and he's in hospital. They don't know where to send him. But not only does he have arthritis in his knee, if you look, his right knee is bent. And the right knee is bent because of chronic osteoarthritis. His hamstring is contracted and short. So he can't get that heel down and it's unstable. So after we do his geniculars, we do intramuscular cryoneurolysis to the semimembranosus, semitendinosus, and the muscle extends and he can walk much better. So we are adding in muscle dysfunction, not just spasticity, any shortened muscle. So now we're going to start looking at some cases, and we have to determine why is this patient in pain. And again, I'm a functional physician. So this is an 80-year-old woman with cerebral palsy, which you don't see as many. And she was admitted to hospital because she suddenly could not walk. And she had severe tone in her legs, couldn't walk. Full x-ray screens didn't show anything, probably some age-related spinal stenosis in her back. But she lost the capacity to walk. She wouldn't be able to go home, and her family was thinking she'd have to go to care. So if we look at her, Dr. Ibrahim Ali here is trying to transfer her to the bed, and she's developed a severe adduction spasm. So she cannot open her legs. She cannot stand up fully because her hamstrings are contracted, and she has a significant equinus of her foot. So can't walk, two-person assist to transfer. We are going to didactically go through and decide where this tone and pain are coming from. We're going to treat that, and then we're going to get her to stand up. And this is from someone who has not walked in weeks to motoring. And this is the same patient. We just went up at 6 hours later to make sure she was okay, and she's walking independently. So this is what happens, and this is how we assess our pain. She can't extend her legs, so her hamstrings have developed new and worsening tone with her cerebral palsy. Both hamstrings are extremely short, so you can't straighten your legs. You can't stand up. Her right ankle has developed a lot of increase in tone, and the adductors are very, very tight. And if you know, if you do a peng block, you know, the targets for the peng block are obturator. So there's probably both adductor pain pulling on the hip, but when we do a peng or an adductor block, we also release those adductors. So you can see dramatic improvement in her function. Going to care, going home, she was doing stairs the next day. So the question is, what came first? Do they have the spasticity? Do they have the pain? Do they have the arthritis? Where is this interplay? And I really don't care. This is a patient of Dr. Vincent who was admitted with a stroke, not able to walk. So she hadn't walked in many, many, many weeks. She'd been increasingly frail, admitted to hospital. And I don't even think she had an acute stroke. It was probably chronic lacunar infarcts. And Dr. Vincent, you know, she can't walk. We're holding her up. That's the extent that she's going to walk. So if you're a physiotherapist in the hospital and an occupational therapist, you need to get this person stable to go home. But she says, well, my knees hurt. Well, you've had knee surgeries, multiple in the past. surgeon says there's nothing to do, it's her stroke. But you're a neuro expert and you're like, actually, no, the neuro exam is pretty stable. I don't really see signs of an acute event. So let's just go after the knee. So in this case, all we did was focus not on the neurologic, just on the classic genicular, super and inferior branches that we do, and then we're going to assess her. So again, we always have to think, is it pain or is it neurologic? Remember, she's not walked in like nearly a month, so I don't want her to go vasovagal on me, but she's starting to walk. And one of the reasons why I'm showing these videos and why I wanted to do a presentation today is we talk about pain outcomes based on visual analog score or other options. But the issue is it's functional change that patients want. They want to wash their hair, they want to walk, they want to play with their grandchildren, they want to get on the ground. So we have to look at, what is it? So I don't think anyone could watch this video and say, wow, from doing a treatment for her chronic knee pain and her surgeries, she is now better. After, weeks in bed, she's going to walk. So she's going to get her walker here and she's going to walk out and she'll be discharged home very quickly after being hospital frail for weeks. She doesn't need any type of stroke rehab. She's just going to walk. And she just walked to the end of the stairs. And we can
Really
now see
interesting.
her stability. Okay.
Dr. Wilson, this is
So,
a
No,
life
Paul?
changing for me because after Malik's back
oh,
surgery, before we had the cryo, he was in pain everywhere. I couldn't get everything. He was so tight, his leg would be like that. Now I can stretch it and I can open his tie, change his diaper. So I'm very, very, very pleased with it. This is so awesome. It's a life changing for us. I love it.
so this is a mother in Atlanta who was treated and by the team of pediatric physiatrists there, and the mom was so happy she wanted to send us a message because her young child who was brain injured lived in pain, and again, probably doesn't have arthritis, but severe tone causes a lot of pain. Jose, did you want to say something?
Yes. I'm really impressed with those cases, the first cases you showed, and I'd like to make just a comment because I think everyone who's listening and watching us now must have a case like this not very far away where from there they live because. And I think, especially these frail patients that stay a long time in the hospital, it's a self. I'm criticizing myself, but also my colleagues. Sometimes we give up too early on these patients. This is the impression I have, and what you are showing is that at least we can offer them something, and you can also do blocks to test the hypothesis before advancing to a cryoneurolysis treatment. But what is impressive what you're showing is that you are somehow investing in patients that in a lot of hospitals they will be labeled not to invest. So it's a big shout out for your work.
Thank you. And I think you brought up the most important factor there is that we do blocks first to assess. So we often don't know what's causing the pain, or we got it wrong, or we're not sure. And by doing this series of blocks, you're like, wow, this really is a tone issue. This is really a primary pain issue. So that allows us to invest in the patient. And I think that's the key that we're realizing is that we can now kind of figure it out. And even more important is that we'll have study after study, and people will argue if regenerative medicine or cryo will help knee pain, right? Because the patients are
Mhm.
so heterogeneous. This is a hospitalized population that had an acute death that brought them to hospital. So if you can
Right.
treat their knee pain like you do a rib fracture, if you get rid of the rib fracture pain for 3 months, the issue
A
isn't a
lot.
problem anymore. So if I can get
Yeah.
this frail elderly person walking again, stronger, exercising, they'll go back to their baseline of walking 10 meters in the kitchen. So
Yeah.
it's a very different relation because you're actually giving them the functional goal that they need.
You are
Okay,
taking
we
them
can go back to the
actually out of
presentation.
this frailty cycle. Go ahead. Very interesting. Go ahead, Paul, please.
And if we have the slides, great, perfect. Now, here's another case. So we get patients brought to us from long-term care, and I actually my equipment's portable, so I can go to the long-term care facility. And these are patients that are getting maximum dosage of botulinum toxin. So this man would have gotten 600 units of botulinum toxin for about 5 years. But, as I said to the reps for the toxin industry, all of that was off-label. MS is not covered in most countries, like Germany, all over Europe. MS is not on the label for toxin. It's upper leg, so the adductors, the hamstrings, the hip flexors, those are generally off-label. So treat people off-label with toxin, but what's really off-label is it's not spasticity. This is contracted, shortened muscle. And what I want to explain to you, when we do cryo, we are relaxing muscles by targeting their nerves so the muscle can go to its full extension. And in some people, it will still have a degree of contraction, but so many people who we thought had no potential to extend when we take out the nerve. So, this man can now sit straight in a wheelchair when he was just confined to bed. And again, a lot of these things that we're talking about, we have put in the literature with all the instructions on how to do it and videos of the patient. So if you said to one of your colleagues, "Hey, I'd like to try this," our publication will actually show you how to do it. So this wonderful man, he's an incredible artist. He is a quadriplegic, so he's got his hands. I had treated him years ago with maximum doses of toxin, and then he saw a colleague after that, and basically, his hip is stuck. And the surgeons will not operate on a hip like this because they'll just dislocate their hip immediately. And there's just too much to cut in terms of the tone. So we did all of these targets and his legs go straight. So you can see from that, he's basically stuck. He can't do independent transfers. He can't do independent toileting. He has a catheter and neurogenic bowel, but now he can sit straight. We also treated his fingers, and he has much better finger control, actually can brush his teeth and do a lot. He's a wonderfully independent guy otherwise, but he can transfer in and out of the shower, in and out of his chair. But it was the pain in his hip. And the thing about spasticity is any noxious stimuli will make spasticity worse. So for these patients that have tone makes their pain makes their tone worse. So it gets worse and worse and worse. And again, for someone like this who has spinal cord mediated, the tone and clonus will return when the nerve regenerates. So at about 9 months, we would need to retreat those legs. Often for spasticity, it lasts much longer. But hey, every 9 months, I think I've treated him twice now for those legs in 3 or 4 years. He's doing well to the point where he can now have a hip replacement. I'm actually advocating for a girdle stone just to take out the whole humeral head so that he can, sorry, the femoral head.
Mhm.
See if I can advance my slide here. Hold on. Okay, perfect. So going back to this idea of arthritis, we as a group in cryo do not publish a lot. We have very, very little publications. And what I also want you to do is look at function. So this is a end-stage cancer patient. He is palliative, has an incredibly supportive therapist wife, and she's like, he can't do anything himself. Like he can't. I have to do everything, which he doesn't like. He can't feed himself, toilet himself. His shoulder pain is so bad, he can't have surgery. So if we look at his x-rays, it's quite advanced. So in this case, we just did suprascapular, which we've changed, which all of you have done with your cryo. But what I want you to know is that we are looking at functional improvements, not just pain. He doesn't care about his pain score. He has tremendous pain all over his body from his cancer. He wants to know if he can increase function. So I'm asking you in your hospitals, can you come up with some kind of outcome score? So, this is a man who his range of motion is very limited by pain. So, he can't reach the toilet. He can't do so many tasks. He can't reach his hair. And we are just going to give him enough range of motion that has reduced pain, that he can get his arms overhead, he can touch his face, he can do, clean his face. He actually got up and stand and, made dinner for his wife. So these are the functional goals that we need to look at. And of course, we also do the lateral pectoral nerve as a part of shoulder pain, which can also relax the pecs and increase range of motion. So when you're seeing these arthritic patients, what I want you to look at is move the joints. And when you move the joint, do you feel muscle restriction? Are the lats tight? Are the pecs tight? Have those muscles shortened and contracted so that they can't have full range. And that's how we're going to do them. We can just turn up the volume here. So this is kind of like the ultimate example. This is a patient whose goal is a non-functioning stroke.
This allows us to selectively freeze the nerve fibers that are responsible for spasticity.
Oh, beautiful. Wow. Okay, now I'm gonna cry. And can you wiggle your fingers or move them?
So this is a woman who, she has what we call contracture. There's no range of motion in that shoulder. It is stiff and contracted, and we don't know what's coming from pain and tone. So in fact, we're going to start with a suprascapular nerve block, just with lidocaine to see, can we get more range of motion? Is she just protecting and guarding? So we'll start with the pain, and then we're going to go after her pec muscles. So, she still holds in that tight position. It straightens out, but that's just her stroke pattern. But you can look 1 year later, she has really good range of motion. So in terms of me, I'm thrilled that 1 year, no botulinum toxin, she has such a great result. Her walking is better, but she wants more. So we have been adding and adding muscles. So this is a axillary approach that we call where we do subscapularis, teres major, and latissimus dorsi in a Neapolitan 1, 2, 3 layers. And by adding that in, she's suddenly very, very supple. And the difference is she has no pain, right? Look at her laughing in terms of how she came in. So that tone is incredible. So, about once a year, she'll come in for a top up. Similarly, she had a very poor gait when she came in, and we're going to treat the leg as well. This was after we treated some of her leg, but we max out at about 20 different nerves. It's a really long treatment, so we didn't do everything. But the second time, we added more muscles, and she can walk so much more. So just so that you know, some of our procedures last 2 hours. They're very long. Just gonna that's my slide. So if you're interested, this is that arrangement that we're doing on our patients all the time. And we could never do this approach on patients without treating the pecs first. So cryo is an additive procedure. Their arm is like this. You get rid of the shoulder pain, they do this. You get rid of the pec and they can abduct. And now because of this, we can then go into the axillary region. And this is the article, if you want to take a screenshot, that really shows this view. So again, I have written a lot of work on early management of stroke. So this is a wonderful patient of ours, an Indigenous woman, a Native North American, and she was in so much pain about 12 weeks after her stroke. She was actually getting worse and worse. She was discharged home, doing well, and referred to outpatient. And the therapist said, Paul, she's in so much pain, I can't move her. So she's in agony after her stroke. And, she was actually speaking like a young, scared child. And, very afraid of us, very afraid of the doctors, afraid of pain. And when you examine her, you're like, this is actually shoulder hand syndrome. So after stroke, we can get a version of complex regional pain syndrome. This is a classic capsulitis because not only does she have spasticity, but her capsule is short. So even though it was very painful for her, we did a capsular hydrodilation anterior, which I do all the time for these pain patients, a suprascapular, a pec, and a biceps. And she got dramatically better. So it was actually the frozen shoulder, the capsulitis, that was the most limiting factor. But by treating the spasticity as well, it works. And I've been spending years on this, something called the VIVA algorithm, Victoria Verona, VIVE, looking after stroke. Why do people get contracted? So many patients that show up to the neurologist 3 or 4 years after their stroke, they probably had a degree of capsulitis in the shoulder at the beginning. They had CRPS in their hand with that fisted hand. So it worsens the spasticity. And she's just so happy. And we did her wrist eventually about a year or so later, and she's just thrilled. So, she's actually a very articulate articulate woman. She's a university advisor. She's a high school science teacher. And I tease her. I said, you acted like a little child when I saw you because you were in so much pain you couldn't speak. And now we're having conversations about science. So, pain really does change your life. Um, This is just to show you that the functional improvements we can get with cryo. This is actually not a pain patient. She is a brain injury patient from Texas that had best in the world care. She has a baclofen pump. She had Achilles lengthening. She had toxin by a great doctor, but it just doesn't give her functional improvement because it doesn't work. We did pecs, we did her biceps, we did her brachialis, and we did her wrist. And she goes from having no function in that hand to being able to do her hair. And everyone says to us, if you treat the muscle, won't you make the patient weak? And before the procedure, she could close her eyes. She's a little disinhibited from her brain injury. And she said, look, I can punch you. And she smacked me on the arm. But that was it because I can't move my arm again. And we did the whole procedure. And then a year later, we added that axillary group and she's boxing. She can do everything with that arm now. So we're not making our patients weaker. We are lengthening their muscles so they can move functionally and without pain if they have pain. Can we turn on the volume here to make sure it's on? So this was one of my first hand contractures. 9% of nursing home patients in America and Europe will have
How does
this.
this feel?
Oh, good.
Good?
Feel bad, bro.
Okay.
Does not feel
So
bad,
we're able to
bro.
move the fingers now, which is a big difference.
That's
We're able, if you look here,
loosening out there.
we can see there's some maceration in the skin that we've opened up. And then these fingers, we're able to start opening too.
This is not spasticity. This is a polyneuropathy, aging. And so what I want to point out, this was one of my very first median and ulnar trunks where we want to both anesthetize the hand and we want to get rid of their tone. So we're not going to open him up, but the stench from this man. Both hands smelled like they were rotting. The elbow crease smelled like it was rotting. So we are now treating these patients from long-term care to open them up enough just so that their wounds heal, do not become infected, do not worsen their tone, but just to give them pain relief. Many are on opioids, they're on Seroquel, they're on antipsychotic medications to sleep because they're in pain. We have amazingly just completed a study of 25 inpatient or people from long-term care with contractures of their hand. And I'm really excited to kind of show you some of these. So this would be our classic patient. Lovely care, great nurses, attentive family, he's advanced dementia. They can't touch him. They can't do therapy. They can't do anything for his hand because he's like this. We do the median and ulnar. The hand opens up. I can't touch his fingers. I'm able to trim his fingernails and the wound has healed. So after I do the procedure, I actually start pulling the fingers open and you hear this horrible as you basically break the capsule. So it's not even spasticity, it is dementia related atrophy, disuse, and pain. And now I can just pull his hand open because I've completely anesthetized the hand. We can become highly, highly selective.
I'm gonna try to open this one. That's about as far as we can get there.
Open and close your hand now. Open and close. And if I do this,
Oh.
okay, painful. Sorry, we won't do it again.
So Dr. Muse is showing how she chose. So this was my colleague's patient. I just filmed it for. So we decided that she didn't need median and ulnar trunks because she didn't really have pain in the other fingers. It was those two fingers that were stuck that were so painful. So she's going to do a hyperselective intramuscular branch, which you can do. I've done it with, I've done it with Metrum many times. All different products. We can do this easily because it's not the machine. It's the driver. And you can see immediately the hand just opens up. So by relaxing the tone in the fingers, it was not a true contracture. It was a tone issue, which is quite exciting. So I'm just going to end with something kind of exciting for you as well, is that I want you to know that our whole body is controlled by muscles. So we can treat anything that has a muscle. And this is a patient with really, really difficult jaw. And we started doing jaw to help at the request of an anesthesiologist mother who wanted her son to be more intelligible, that he'd talk like this from his CP to open his mouth. And she said, I don't have time for toxin because you have to repeat it every 3 months. So she basically forced me to do my first masseters and pterygoids, which I'm very comfortable with toxin. And we just did it in her son awake. And basically, we just go right in here and we just target the muscle, get a beautiful stimulation, pull back both muscle groups.
Open and close your mouth.
Uh,
Open and close. Open and close. Okay. And I'm just gonna put my mouth fingers in. So there's one. Can you open
so this
one
is
more? Do you mind just chatting for me?
Yeah, no
3 years
problem.
after a car
And can you
accident.
just tell us like what happened to your jaw?
I was in a car accident. My face hit the steering wheel and dislocated it, and I was having lots of spasticity in my muscles, causing lots of migraines. And it was very deviated at first, almost like 3 teeth over.
And since we did the procedure, can you just show us how open
Yeah.
your jaw is now? Up and down.
Huge.
Good. So still a little bit of stiffness in that
Some
joint.
stiffness, some cracking, but I couldn't do that before.
And you did say the side effect after your mouth did swell after the procedure.
Yeah, it was like getting your wisdom teeth out for about a week.
Okay, but it's a lot better. And
Yeah.
it's held for months.
Yep.
Okay, thank you.
And the thing about this patient is that the surgeons said they wouldn't operate because the muscles were so spastic, they would just dislocate again. And I tried toxin and a little bit of discomfort, but no functional change. And now it's to the point where we're going to give her about a year, and then the surgeon's going to go in and try to reconstruct the joint. So, but she's actually an acupuncturist, so she's very happy. So, just going to wrap up because I think we're almost out of time, but I just want to tell you is that I combine treatments all the time. So this is an MS patient with the top of her foot burning, and she has a toe curl. She can't feel her feet from her MS, but her feet claw and the top of the feet burn. So we're going to do both the intramuscular branches of the toe claw and the superficial fibular nerve. So we combine these all the time. So in this case, I've already done the toe, so she can open the fingers, but the top of her foot was burning and she's looking at her feet going, I can't believe how nice my foot moves. We haven't done the toes on this side yet. So she can't open and splay the toes and they're still burning. So this is, what we're showing how we are going to combine pain and muscle. And this is after. So now the toes on the left have been treated. She can splay her toes and the top of her foot is no longer numb. All right. So I'm just going to end here with a little bit of joy. We see a lot of patients that have been
Wiggle your
told
toes.
there's nothing else that you can do.
Well, what's different? Your toes are wiggling.
It's pretty great.
And how about when I touch here?
It's still not great, but it's way better. You can touch it.
Awesome. Okay.
My toes.
So I did a
Up and down.
tibial sensory
Amazing.
and her toe flexors long.
Yes. Again. Excellent. Yes.
5 years in a wheelchair.
You did it. Okay. And go. Beautiful. Yes.
So the surgery
Holy shit,
helped her
babe.
get straight, but the severe
Amazing.
pain burning in her foot and the toe curl meant she could not use it to walk. She has functional neurologic disorder, so she will get pseudo seizures. She will get all the behaviors that will not allow her to get better. So we have to work within her FND, and when the pain returns in her foot, we have to treat it again to make sure that she can walk.
Okay. Next one.
And the surgeon did two surgeries first, and then has to do one more.
Okay. Now walk towards me. You kick them.
And she's walking barefoot, right? So I repeated the sensory branch. And the toes still are a bit short after all the surgery, so the surgeon's just going to lengthen the curly toes, which he did. So by addressing her neurologic disorder, her contracture disorder, and her pain, we were able to get her functional. All right, here we go.
What a great talk, Paul. Really, really great. I mean, while I was watching you explaining all this, there is first idea is clearly that the message for us doctors that you are encouraging us not to give up on patients. You know, these examples you gave on these dementia patients with their hands closed. We listened a lot to even the nurse caring team sometimes it's like they don't for them it's already the end, and I think it's a really great message, a take-home message, really important message that you are giving us and encouraging us. And secondly, a thing that I would like you to comment is that, like this last case, is the way you can, at least with this technical craniolysis, you did this like stepwise approach and really patient centered. I mean, you define a strategy in a clinical evaluation and for the therapy, and you go with a treatment with some parts of the muscles or pain, and then you increase further and see them. So this is some flexibility that I think you cannot find with other therapies, even surgeries. You cannot find this. What's your comment on this idea of the stepwise approach and the flexibility cryoneurolysis can give you to our patients? And thank you very much for your
And
amazing
I think
talk.
I think Jose, that's really interesting because this is new and we've had to prove it works. One of the things is that we've have to prove that the longevity of it. And even in our studies, we did a year follow-up, which is unheard of for spasticity. And it meant that we had to justify to everyone, like I got a grant to do this. I had no funding. So I had so many probes per patient. And you wanted to get it all done in one session to prove it works. And in many countries don't have remuneration codes. Who's going to pay for the procedure? Well, the patient and you. And it's really cheap. Like for me in my center, it costs 450 US dollars to treat one patient. That's it. It's nothing compared to toxin. It's nothing compared to so many things. So we were sort of forced to say one and done and hope. And now I'm like, no, because what happens is the patient, you know, they're a bit scared to do their hamstrings and quads because every doctor they saw and their physiotherapist said, if he treats your thigh, you'll fall down. You can't walk.
Mhm,
And that's why we do the blocks. But we'll do the thigh. And I'm like, yeah, but you can't do stairs. You can't do stairs because your hamstring is too short. Please let me add in your thigh. So we add in the thigh. So at the beginning, I felt like I was really forced to do it at one time and then that works. And now what we're doing is that we do the shoulder and they come back, it's still stiff. Like there's zero tone. It goes right to end range. This is capsulitis. And then we go to do the
mhm,
capsule. And as I put my needle in the shoulder, I'm like, I can't get my needle or my right. I'm like, yeah, that's calcification. They're completely
mhm,
calcified around the rotator cuff from disuse. So let's break up, do barbotage. Or you know what? The
mhm,
tendon is contracted. We're going to do a pectoral
mhm,
tendon release. So what we're doing now is we bring them back at 3 months, should be the maximum spasticity improvement, and go, it's not good enough.
mhm,
What is the
mhm,
functional? Do I need to do surgery? Do I need to do a capsule? I'll often just hydrodilate the wrist with saline just to get it to move. I'm doing fascial releases of the tendons. I'm saying, look,
mhm.
I've got your foot flat, but you're going to need a brace for the rest of your life. Why don't you go get surgery and we can do a tendon transfer and you can walk without a brace? So I've now given myself permission. It took a long time to say you don't have to get it all done right now. We're going to do
Yes.
this and see how much better we can get you, and then we're going to reevaluate.
Completely agree with you. I mean, in our center, we are doing also this stepwise, and I think it's for the patient also to accept, and also for us to diagnose what happens after cryo. And I see a lot of these contractures and also capsular alterations like frozen shoulder, and of course you have to add new targets. The billing is actually a big problem everywhere. I mean, this is something. In cryoneurolysis community, there is some lobbying that must be done to the agencies, that social security or insurance, because it's, in my opinion, I think, as you said, it saves overall, it saves money for the society, for the healthcare. So I think, in my opinion, I think it is very important to start also on this area.
Actually, we just put in a proposal to the anesthesiologists own our fee code in Canada, and I actually got audited by the government. Like, why are you guys doing so much cryo, you group of 5 doctors and some anesthesiologists? What's going on? And the doctor knows me from the government, and he's an old colleague, and he's like, Paul, I'm sorry. How long does it take you to treat that patient? I said, that was 2.5 hours. That's a quadriplegic patient who needed 25
Mm.
lesions. He's like, but the fee code is for like 3 nerves. I'm like, I know. And we've got our anesthesiology department. We have an incredible rib fracture program now. Either they do it or we do it. 8 ribs, bilateral.
Mhm.
So it takes 2 hours
Yes,
because the patient's so fragile, but they go home the next day
yes,
or a week later.
yes.
And so we are actually going towards time-based fee codes. We're asking, can you please change so that we're not feeling rushed or we don't have to justify it's 2 nerves or 4 nerves. If it's a 2 hour procedure, we'll get paid for 2 hours. If it's a 30-minute procedure, we'll
Yes.
just bill 30 minutes.
I would say in some countries, like in France, they have this status for disabled patients. So it should these patients that are there is a consensus in the doctors that control that they have this kind of disability that is somehow irreversible. It takes a lot of time taking care of them. I mean, even to do the clinical exam, even to undress these patients, and this time means time for the doctor and so on. So I think they should have like some kind of positive discrimination in the billing of these patients, and it should incentivize the treatment of these patients with disabilities, with dementia, and so on, less suffering, and I think more caring of the disability patients.
Question
So
for
in
you.
my
So I often say, oh, go ahead.
No, I mean, I was saying this is something. No, it goes beyond the talk, but it's something that is in disability medicine, where you are and where I work. We work with the other disciplines, well, other professionals, and it takes a lot of time to invest on them, but it's very rewarding treating them. And small changes means a lot to those patients. I mean, in terms of function, in terms of pain, in terms just sometimes staying upright and being able to explore, doing visual exploration of the environment in the so this is so important that people we are not dealing all the time with the patients with disability. They are not aware, the professionals, so it's very important to invest on them.
So I sort of would like to get people to give you a minute to explain. So just so that you all know, Dr. Vincent did our first case in 2018, just one brachialis, and we advanced. And then I presented it just by fluke. I was presenting a talk in Paris at the International Rehab meeting, and I added in our first case. And Jose saw that case, and he went home. And a year later, he said, "Do you mind if I present at ISPM next year? We're doing this as well," which was really exciting. But he did I recommend at most centers is you go to your hospital, you go to your anesthesia department, or if you're anesthesia, you go to your rehab department and you do it together. Because anesthesia has the equipment and the know-how, but we have the skill set to select the muscles. So I've been working with a lot of anesthesiologists who are now, doing cryo for spasticity. But if you work with a rehab doctor, you become a team. So one of you teach each other, but we are reproducing it around the world. We're now over 30 centers in Europe, over 30 centers in North America, very, very quickly through this teaching. So do you want to just explain very quickly how you see a partnership working like in Europe?
Completely agree. Completely agree. We I think a lot of anesthesiologists are showing a lot of interest in the spasticity patients, but again, it's very important to understand the impact of spasticity in function, because sometimes spasticity is helpful. So you should not treat some muscles that are very spastic because they are important in weight bearing or transfers and so on. So it's important to team up and also include the patient, the mothers, the husbands, the children of the patient, the caregivers, the therapists who deal with them in a routine basis to define the goals. I think this is what we learn in our specialty, and this is how also I think it's interesting when we are with anesthesiologists is to when we live in this kind of interfaces. And this is what I think when I heard about what happened with Dan Vincent and you. It's like, is there that things happens, innovation happens, where people discuss, where there is some brainstorm, when not in the center, in your core of your activity, you have somehow to go to meet other colleagues because they are having other problems, they have a different mindsets, and it's the conversion and discussing with them that we can really evolve, I think. And I believe the story with Dan Vincent and you is really, really crazy because you were in Victoria, in Vancouver Island, in British Columbia. And I was also here in Luxembourg with my colleague Fred Chantren, and we were doing a lot of motor blocks. And you take this idea also, the motor blocks, the French, they developed it a lot before. And I was almost thinking, oh, it's going to die, this idea, in one generation or so. But you take it, and then there is the ultrasound, because ultrasound changed a lot, and you made it. It's great. Great talk, Paul. Thank you very much.
Thank you.
Wow. Wow, once again, that was an amazing presentation and great discussion. It was the first time when we had you both, but definitely not the last time, because the cases you have, the work you do, and how amazing it is to see the results immediately after all the procedures. It's, people are speechless afterwards. So I would like to say a huge thank you to you both for your work and for taking part in this discussion, taking part in our event. Thank you so much, and see you soon.
Thank you.
Thank you.